It's very difficult to speak after Dr. Hirsch and Dr. Murana and Dr. Sadaf. They are great speakers and enjoyed their talks. Thank you very much, Dr. Sadaf, for describing my lecture as elusive, because it is. This topic is really elusive, and I actually was trying to find the word to describe these indeterminate splenic lesions because they are all indeterminates. My name is Khalid Elsayes. It's my pleasure to speak with you today in London. In the morning, I was in India, so it's the very interesting virtual world. So I was giving a lecture in India as well. So today I'm going to speak about this elusive topic, which is indeterminate splenic lesion. Okay, I have nothing to disclose. You know, it is really very difficult to characterize a splenic lesion. And that's why you see hundreds of pathologists involving the spleen. That's why you have to come up with some sort of an approach for your diagnosis, an approach to reach a specific diagnosis. And today I'm going to propose an algorithm based on what you see on imaging and based on the literature description of these lesions. First, I would like to warn you of looking at the spleen in this early arterial phase, because as you see here, you see this serpiginous enhancement. That's what's called arseniform pattern of enhancement. So if there is only a single phase of imaging, then you should use the venous phase, not really the arterial phase. So I want to warn you of this because this could obscure lesions like what we see here. We see multiple small lesions in the spleen. You see them only in the venous phase when the spleen is homogeneous, right? In this heterogeneous spleen at the same scan and at the same level, you don't see what you see here, which are these diffuse small lesions in this patient. So this is first lesson is you need to choose the venous phase to evaluate and avoid the early arterial phase, which has this arseniform heterogeneous enhancement, which may obscure lesions. So the first lesion is that's the easiest one that we all know and we are all familiar with the imaging features. This is just a simple cyst, and simple cysts in spleen are true cysts that have endothelial linings, and we know that it measures less than 10 Hounsfield units on CT, no enhancement on MR. It's very characteristic, low signal intensity on T1, hyper intense signal on T2 without significant contrast enhancement. It's not treated unless it's symptomatic. If it's asymptomatic, then we do cystectomy to the cyst. Another lesion here, very important lesion, which is an abscess. This is also, we can describe this as cystic looking because it's typically low signal intensity on T1 and high signal intensity on T2 and not enhancing. It may have like some sort of peripheral rim enhancement. In this patient had pneumonia, and this patient has hematogenous spread. And in this particular patient, we see the lesion as high signal intensity, relatively high signal intensity. I would say slightly hyperintense because of the proteinaceous content. So abscess could be either low or relatively increased signal intensity on T1 secondary to the proteinaceous contents due to infection. And this is abscess. And if we talk about abscess, it's secondary to hematogenous spread, and we know the risk factors of it. Rim enhancement could be occasionally seen, but not in all cases. And as I've told you, low signal intensity on T1, high signal intensity on T2. So it really, you put it in the context or in the category of a cystic lesion, but you are helped with the restricted diffusion due to infection. You're also helped by the constitutional symptoms, the patient with fever, left upper quadrant pain, and leukocytosis, and left side pleural fluid that are all associations with splenic abscess. The less than 4 centimeter can be treated only medically by antibiotics, but larger than 4 centimeter, then you need to drain it and give also antibiotic. And this is a reminder of the case that I showed you with pneumonic consolidation in the lung. The third lesion here, which I would also still describe as cystic, but this is also characteristic for a benign entity, which is lymphangioma. Whenever you see a lobulated cystic lesion like that with thin enhancing septation, then you need to think about lymphangioma in such case, and this is a benign entity. You don't need to do anything about it, and this appearance is characteristic. Again, thin, non-enhancing with thin, lobulated, cystic, non-enhancing with occasionally thin internal septations. Those are all characteristics which point to the diagnosis of lymphangioma. What about this? I mean, this looks cystic too, but it's the signal intensity here is altered. It's a slightly hyperintense on T1, and it's hyperintense on T2. And as we know in MR, and it does not suppress also on fats saturated T1, and it does not enhance. And whenever you see this, this is characteristic for what? For acute hematoma, right? Or subacute hematoma, where you see high signal intensity on T1 and high signal intensity on T2 and no enhancement. But why you see them as well circumscribed like that? In the spleen, these are called traumatic cysts. So traumatic cysts are hemorrhagic cysts which are often traumatic in the spleen, and you just characterize them by the evolution of the blood degradation products. So their signal intensity will be concordant with the stage of blood evolution, blood degradation products evolution. So this is a post-traumatic cyst. But what happened when these cysts become long-standing? That's what happens, which is, and this is characteristic. Look, whenever you see it in the spleen, then you characterize this as long-standing post-traumatic cyst. Whenever you see dense calcified rim in a cystic lesion like that, it's definitely cystic, as we see here, fluid attenuation, very high signal intensity on T2, and you see this densely calcified wall, then this is a long-standing post-traumatic cyst characterized by peripheral calcified rim. This is characteristic, again, similar to a simple cyst or endothelial cysts. Those are not treated unless symptomatic or large, putting the spleen at the risk of rupture. If they are larger than 5 centimeters or symptomatic, then they can do cystectomy to these cysts. Okay. What about that? Whenever you see that in the spleen or in the liver, this is what? This is a calcified lesion, which is characterized by what's called water lily sign or floating membranes. This is characteristic for hydatid cyst. Okay. So why I'm putting this? So whenever you see daughter cysts, as I said, and or floating membranes, then you characterize hydatid cyst. The type 1 hydatid cyst, which is the early stage of hydatid cyst, can be just simple cystic looking, but the wall is characterized by low signal intensity on T2 on MRI. Okay, so we know about the pathogenesis of hydatid cyst. I'm not gonna go in depth about this, but I'm just showing you the characteristic look of water lily sign within calcified cyst. This is echinococcal cyst. So this is the first algorithm I'm coming up with, which is whenever you see single cystic lesion in the spleen, you put it as simple cystic, which is primary congenital, or secondary post-traumatic cysts, although it's not really simple because it follows the blood degradation product in the early stage. Later on, it can look like cystic, and also abscess can look simple cystic unless really you have rim enhancement, but also it is characterized by associated constitutional symptoms and leukocytosis, and perhaps also left pleural fluid and atelectasis as well. Lymphangioma can look also simple cystic. Okay, but what about complex? I mean, a lot of these pathologies above can also look like cystic. When you have peripheral dense calcification, then you think of long-standing post-traumatic cyst. It's pathognomonic, it's characteristic. Okay, echinococcal cyst also has a characteristic look, unless it's really type 1, which can be just simple cyst, although simple cystic looking, although it can have the appearance of low wall on MRI. If it has high attenuation or layering blood, then you think about post-traumatic cyst in acute or subacute stage. And as I said, when it's long standing, then it leads it to peripheral dense calcification. Then lymphangioma can look like complex by having lobulation and thin septations within it. And also biogenic abscess can look like complex, because it may also have some sort of septations and edema and peripheral enhancement. Okay, so the second group of lesions that I'm also showing a pattern recognition approach for these indeterminate lesions is when you see this. Whenever you see this, you have two top diagnostic possibilities. One of them is this fungal microbacterial abscesses. Those are what? Those are numerous low attenuation lesions scattered in the liver. Okay, and when in immunocompromised, you think about fungal microbacterial infections, right? They are typically tiny. They are typically very small, not even less than 2 centimeters, but even less than 1 centimeter, or even sometimes sub 5 millimeter. Okay, but they are typically diffuse, uniform, and in immunocompromised patient, you think about fungal or microbacterial abscesses. What about this? This is a similar entity, right? And I would put this in the top differential diagnosis with fungal microbacterial abscess. I put sarcoidosis. Sarcoidosis rather is characterized on MRI by being low signal intensity on all. That's a nodular sarcoidosis, which is characterized by low signal intensity on all bulk sequences. Here, this is not typical for abscesses, for example, which is characterized typically by high signal intensity. But whenever you see low signal intensity on T2 like that, you think of sarcoidosis. When also they are multiple tiny lesions, diffusely uniform, scattered through the spleen, and can also have minimal delayed enhancement in the delayed phase, like what we see here. Those are minimal enhancement of these lesions. So this is sarcoid lesions here, which could be also in the differential diagnosis. As I said, remember, low signal intensity on all sequences and can enhance minimally in the delayed phase. And of course, you have the supportive evidence of other systemic evidence of sarcoidosis, lab, clinical, and also imaging features of sarcoidosis in other locations. What about that? You see here multiple hypoattenuating lesions. You see just one of them in the spleen, but you see multiple in the liver. This is metastatic disease, okay? So metastatic disease, also some of the tips for metastatic disease is they are rare, but when they are seen, they are often in the setting of widespread metastatic disease. To see isolated splenic metastatic disease is very rare, is exceedingly rare, okay? So splenic metastases are already rare, and they are often seen in the context of widespread metastatic disease. Moving to a different entity here, also multiple hypoattenuating masses in the spleen. Spleen look like enlarged, right? But you have also multiple retroperitoneal and mesenteric lymphadenopathy. And whenever you see that, you think of also lymphoma. So lymphoma can look like that, which are multiple hypoattenuating or hypoenhancing lesions within enlarged spleen. Also the same thing, they are very rare to be isolated involvement of the spleen. They are typically as, an organ of systemic involvement of lymphoma. So you have also the supportive evidence of lymphoma elsewhere, and those are this is pattern of splenic lymphoma that I'm showing you. I'm going to show you another pattern with different disease. This will take me to the differential diagnosis of multiple small T1 hypointense lesions. If you see them tiny, multiple and tiny, then you have the top of diagnostic possibilities: sarcoidosis and microabscesses in immunocompromised patients. And sarcoidosis, you have systemic evidence, lab and clinical, and systemic also manifestations of sarcoidosis. So that will all help you. And also metastases, typically in the context of systemic metastatic disease, lymphoma typically in the context also of systemic lymphomatous disease. But you have these rare lesions, periosis, littoral cell angiomas, and gamma antibodies. I'm going to show you this, which is what? Whenever you see something that is really causing blooming artifacts in the gradient echo bulk sequences, here you see multiple low signal intensity foci scattered in the spleen, which is causing blooming in the longer echo time pulse sequence like what we see here. This is Piliosis. Piliosis is a very rare entity, and it's characterized by multiple blood-filled small cystic spaces. That's why also you see the blood degradation products in various stages. In this one, when you have hemosiderin, then hemosiderin will be iron. Iron will lead to magnetic stability artifact and magnetic stability with lowering signal intensity on the higher echo time pulse sequences. So typically in most scanners will be in phase compared to out of phase, and T2 compared to T1, and you can see that blooming artifact here secondary to magnetic stability. So this is an entity that is called piliosis here when you add by containing hemosiderin. We all know about it. It's infection. It can be due to infection with Bartonella in patient with AIDS leading to bacillary biliosis, and again they are dilated blood-filled small cystic spaces, and it's often it involves the liver, but can also involve the spleen, and there can be some comorbidities like prolonged androgen uptake and BVC, chronic wasting, and neoplasms. Okay. But this will take us to also pathologies containing iron or containing hemosiderin, which also again can be characterized by lower signal intensity on the longer echo time. This is in phase, this is out of phase. You see well circumscribed mass in the spleen with lower signal intensity on in phase compared to out of phase. This is in the setting of sickle cell or hemolytic anemia that can be extramedullary hematopoiesis like what we see in this case here. And this is another entity which is also characterized by iron, and here you see that's in phase, that's out of phase, and obviously this is lower signal intensity on in phase, which is longer echo time in this case, compared to out of phase. This is sclerosing angiomatous nodular transformation. And if you look at it here also, the longer echo time is T2. So even if you compare T2 to T1, you see the lower signal intensity on T2 due to iron as well. What else? It can also have hemosiderin that can lead to low signal intensity foci in longer echo time, like what we see here. This patient, as we see here, there is portal hypertension, cirrhosis, splenomegaly, undilated here, splenic or portosystemic collaterals. You see multiple low signal intensity foci on T1, T2, with the lower signal intensity on longer echo time, as I said, in phase in most scanners, and the T2 compared to T1. This is Gamma-Gandhi bodies. This is the typical appearance of Gamma-Gandhi bodies in the setting of portal hypertension. So again, those are pathologies containing iron or leading to iron, for example, hemosiderin, right? And those will lead to characteristic appearance of low signal intensity on T1, low signal intensity on T2, with lowering signal intensity on echo time, on longer echo time, such as in most scanners, as I said, in phase compared to out of phase, and T2 compared to T1. And this is the list of differential diagnosis. I showed you most of these cases, but I'm going to show you another case here, which is whenever you see large heterogeneously enhancing, maybe low center inside within the spleen, you think about angiosarcoma. Okay, and angiosarcoma is a tumor, aggressive tumor with poor prognosis. Here in this case, those are two cases. This is angiosarcoma, and this angiosarcoma with splenic subcapsular hematoma here, because this is a risk for angiosarcoma. It's aggressive tumor, and although rare, it's the most common primary malignancy of the spleen. It can be preceded by radiation therapy or chemotherapy, has poor prognosis, and there can be these patients can present at the early presentation, or the presenting symptoms can be with a splenic rupture, and the metastatic disease can be seen at the time of presentation. So that's why it has aggressive and poor prognosis. Median survival of these patients is 6 months, which can be prolonged for only a few months if early diagnosed and treated. And this is again an angiosarcoma. And again, you characterize it or you think about it when you see large heterogeneously enhancing mass. There can be some blood products, as I said in earlier slide, that can also contain iron, contain hemosiderin, they can contain blood products. They are also characterized by what's called spoke wheel appearance. Okay, so this is large heterogeneously enhancing mass in the spleen. This is easy one. That's the most common splenic lesion. This is capillary hemangioma whenever you see it as small enhancing like that. And then there is the cavernous hemangioma, which looks like peripheral bubbling. By the way, the hemangioma can have different appearance from the liver, so it doesn't read the book of the liver. So it might not, you might not see it as very high signal intensity on T2. You may not see it as discontinuous enhancement. You may see it as continuous enhancement instead. So this is capillary hemangioma, but this is an interesting case which is characterized by diffuse hemangiomatosis of the spleen. But you also have diffuse involvement of the body wall here. So a spleen can be an organ that is involved in diffuse hemangiomatosis. And hemangiomatosis can be a serious condition because it can lead to life-threatening internal bleeding from bowel hemangiomatosis. When you see the splenic hemangiomatosis, you may think about this entity, which is Kassabach-Merritt syndrome. Kassabach-Merritt syndrome can be characterized by disseminated intravascular coagulation, but also a lot of diseases such as Klippel-Trenaunay syndrome, Kassabach-Merritt, as I said, Turner syndrome, Bick-Woodman syndrome, blue rubber nevus or blue nevus or whatever. Blue rubber bleb nevus, blue rubber bleb nevus syndrome is another syndrome that could be characterized by hemangiomatosis. And again, it could lead to life-threatening condition due to bowel hemangiomatosis. What is this? This is also large, homogeneously enhancing, and it's enhancing less than the splenic parenchyma, like what we see here. But you notice this is a characteristic appearance for this pathology elsewhere, which is whenever you see large mass that is respecting the organ or still not deforming the organ, it's keeping the morphology of the spleen, like what we see here, you have to think about lymphoma. So again, as I showed you in the previous case, it's also typically associated with systemic lymphoma elsewhere, very rarely presenting as an isolated organ of involvement. You have three typical appearances: multiple, single or multiple hypo-enhancing lesions. I showed you the multiple ones in the previous case. This is single lesion, again, conforming to the spleen, not causing a significant mass effect on the surrounding organ. And the third appearance is just splenomegaly, okay, in the case of lymphoma. This is typical appearance. The new case, which is you see wedge-shaped hypo enhancement, peripheral subcapsular in the spleen. This is infarction. Infarction is a lot more common in the spleen, more than the liver, because spleen is an end organ with a single blood supply. Liver, of course, has dual blood supply, which protects the liver, okay, but the spleen is an end organ with just a single blood supply. I think this is last the case. Whenever you see well-circumscribed mass like that in the spleen, which tend to be isodense or iso-intense to the spleen in one or more phase of enhancement, like what we see here. The enhancement we see here in the periphery, in the arterial phase, is due to compression of the surrounding splenic parenchyma, leading to pseudo-enhancement. But here, the lesion on the later phase, you see this as very isodense to the splenic parenchyma. And this is another example in the MRI. Again, you don't have to see it on all pulse sequences, but whenever you see iso-intense mass, iso-intense to the splenic parenchyma, you need to think about splenic hamartoma. So this is hamartoma. Again, I ask you to go and read about this benign vascular disease. And again, the characteristic here is isodensity or iso-intensity. Whenever you see it to the compared to the splenic parenchyma, you think about this entity, which is hamartoma. This is my last algorithm. So I showed you the algorithm with cystic lesions and multiple also small hypo-intense or hypo-attenuating lesions. Here what's my algorithm for apparently solid lesion? And I'm saying apparently for a reason. I'll tell you why now. So when I see single large lesion, I just say, okay, think about whether this is wedge shaped and hypoenhancing, this is infarction, that's easy. Metastatic deposit can be multiple, but usually in the setting of diffuse metastatic disease. I showed you extramedullary hematopoiesis containing iron. I showed you SANT, sclerosing angiomatous nodular transformation containing iron as well, which can be single lesion and hypoenhancing compared to the splenic parenchyma. If it's isoenhancing, so if it's hypoenhancing, think about these entities. If it's isoenhancing, think about hamartoma. If it's enhancing, look at the pattern of enhancement. If it's heterogeneous and large mass, like what we saw, think about angiosarcoma. Metastatic deposit also can be heterogeneously enhancing based on the nature of the primary tumor. Hemangioma, the capillary hemangioma, is typically small and homogeneously enhancing. The larger one can be cavernous hemangioma, can have peripheral enhancement as well. And then if you see homogeneous peripheral enhancement, think about those entities again. Hemangioma can be this can be continuous. I mean, this can be different from the common liver pattern of hemangioma. And then very rarely littoral cell angioma. I have a case, but for the sake of time, I didn't show it. And I said, why I said apparently, because those can be, some of those can be cystic, like microbiopsies are like cystic, right? But since they are too small to characterize, they appear hypo enhancing on CT and the MR, and may not be able to characterize them as cystic. Again, multiple small hypoattenuating masses can be microbiopsies, sarcoidosis. Those are for the tiny ones. Relatively larger ones, think about lymphoma metastases, again, in the setting of the systemic involvement. And then you have rare causes, which I mentioned them. Okay, the last case here. Okay, let's have a game, apply it. And, I'm going to confirm Dr. Sadaf's description of the elusive splenic topic. The biopsy here was inflammatory pseudo tumor. Although the overwhelming majority of radiologists will think of this as angiosarcoma. I mean, the majority of us will think of it as angiosarcoma because it's heterogeneously enhancing, has low signal intensity in the middle, like one of the descriptions, and spoke wheel appearance, like one of the descriptions of angiosarcoma. But this is biopsied and found to represent an entity which is inflammatory pseudo tumor. I mean, I don't like pseudo tumor because it's more of inflammatory reaction or myofibroblastic reaction rather than tumor. Okay, with that, I hope you remember these algorithms of the cystic lesions, the multiple solid lesions and solid lesions, and which would help us in diagnosing splenic lesions, although some cases would still remain very difficult to characterize. With that, I conclude, and thank you very much for inviting me to give this lecture.
Thank you very much. Those were 3 excellent talks, and I'd like to thank the gentleman for those wonderful lectures. I'd also very pleased to tell you that there are no questions on chat. So apart from one question that was for the adrenal tosser, clearly not clear enough as well as the gentleman. There was a question about whether it was safe to raise the attenuation value to 20 Hounsfield units based on a paper that was published in The Lancet last year. Well, I can't answer that presently, but that topic is being debated in the update to the European guidelines, and we are looking to see whether we can change the 10 Hounsfield unit cutoff. So stay posted, but we don't have an answer yet. Thank you very much, and thank you very much for joining us this afternoon.